Welcome everyone to this roundtable on the future of healthcare. I'm delighted today to be joined by three distinguished speakers who each represent critical facets of healthcare from around the world. First, we have Professor Tom Pinkney. Tom is a general and colorectal surgeon from the UK. He faces the day-to-day realities of delivering surgical care. The challenges we discuss, Tom actually lives on a daily basis. And as if being a busy surgeon weren't enough, Tom is also deeply committed to clinical research, with a particular focus on preventing surgical site infections. Tom has led pioneering global research initiatives that are shaping the standards of surgical practice. Welcome, Tom.
Thanks.
Next, we have Dr. Bernard Dunn. Bernard is Director of Innovation and Strategy at Singapore General Hospital, a hospital I've had the pleasure of visiting several times. I've always been struck by how boldly they embrace innovation to deliver high-quality care. Singapore General Hospital continues to be at the forefront of digital transformation in healthcare, and Bernard is a key force behind that momentum. Welcome, Bernard.
Thank you.
And last but certainly not least, Joe Mullins, a man who needs no introduction. So let's get this discussion started. So maybe I can ask Tom and then Bernard for really an opening comment.
For me, the acceleration in the speed of innovation progress. The Human Genome Project was a seminal project, took 13 years and $3 billion to map the one human genome. That was published in 2003. And now, a little over 20 years later, we can do that within an operation. There's a great paper around neurosurgical use of whole genome sequencing within surgery, which is great for our patients, but I think it's pretty scary as well. Mm-hmm. You know, as from an industrial point of view, from an innovation point of view, that window of opportunity to identify what's going on and act is getting ever smaller each year.
Absolutely. And Bernard.
Something that is quite scary, which is sometimes we know what to do, but we don't do it. And this refers to the point of the long train and the short train. It reminds me of Kodak. Most of us know Kodak, but many do not know that they actually invented digital camera in 1975. They have all the patents. Unfortunately, they did not act on it. And we all know where Kodak is today. So it's quite scary.
So Joe, maybe the first question to you. Human progress being a series of aha moments where we think differently about how these breakthroughs can be held back by echoes of past mindsets. And I think that's something very relevant to Mölnlycke. We have a strong history of innovation, from safe tack, procedure packs, double gloving, post-op bathing, and that really is part of our challenge, because these achievements can hold us back. Just because we've been successful in the past doesn't mean that we can sit back and just expect to be successful in the future. And I would say somewhat controversially that, you know, we wait for things to happen rather than driving things forward. So, Joe, as a global influencer in healthcare, what do you see as the next aha moments that will deliver 100 years of progress within the next decade?
It's a really good question. So first of all, the past didn't move as quick as the future is going to move. Right? So when you have an organization that was built on a predictability of the past, and that predictability was around an analog world and a manufacturing environment, and it's clear the new world is a digital environment. And that's not a skill set that's native to a lot of healthcare organizations, including Mölnlycke there. And when we think about the wanted state, we only need to be directionally correct. We don't have to be precise. A lot of organizations that have mastered their area of expertise are all about precision, highly predictive. But you need to be directionally driven. And as Bernard said, that you've got to not stand where you're accustomed to. So that's one. The other was the sites of care. So there's two areas right now. Episodic point of care, that's changing dramatically right now. It's moving upstream. And if you're an expert in that area, but you're not upstream in the way healthcare is going to be dictated moving forward, you're going to be at risk. And then there's let's call it the sites of care. Ambulatory surgical centers are starting to get the secondary and tertiary complicated cases. Hospitals will still handle the high acuity cases. That's changing. Buying patterns are changing there. Who you have to influence are changing there. Your leverage on the current buyers, the procurement, and the clinicians is going to be compromised if you don't start to move your product upstream. So I would say that's the second. And then the third is the pivot. He talked about the pivot. There's the challenge for leadership. You've got to be ambidextrous. You have to have one hand in the past and another hand in the future. And there's a phase transition that occurs between leading those two transitions. And you have to have the courage, because that, let's call it, that hand in the future is going to be the threat to the hand in the past. And as I mentioned this morning in a conversation we had, the goal there for the future hand is to put the past hand out of business while keeping that risk inside your organization, rather than having an external competitor do that for you.
And just to follow on from that, what do you think are the mindset barriers that exist that prevent these breakthroughs from occurring?
Well, there's a couple, and we chatted about this over dinner last night. You've got a structure issue. Generally, it's not the people. The people are susceptible to the structure of the organization. So that's one. Organizational structure. Is it aligned with where the future's going? So you've got structure, you've got aligned or misaligned interests, and then you have a commitment that you're willing to take the hill for, regardless of all costs in the future. And that's usually where you have the issues. And then it's the talent. You're going to have to bring in talent here that probably graduated from university in 2005, when you've got probably 50% of your organization that's been employed here before 2005.
Correct.
And those are your digital Sherpas of the future. Now, they're not going to have the wisdom that the current employees have from the past, but they're going to have the information and the knowledge that when you join that together with the wisdom of the current experts, then you've got something to compete with where the future is going to be.
Thank you, Joe. So, Tom, we all know that healthcare systems around the world are a burning platform. We can't really address this while we continue to focus healthcare expenditure in the area of treatment, be that managed or curative care. And we really need to start to focus on preventative approaches, but also patients, or even individuals, don't call them patients if they're not sick, but individuals taking responsibility for their own personal health. This is obviously going to require a transfer of knowledge from the healthcare community to individuals. It's also going to require real-time data flow. And this can very much be enabled by digital technology. But Tom, as a surgeon, you often operate on conditions that are a result of someone's personal lifestyle and their lifestyle choices. So I'd be really interested to know what your perspectives are on preventative care, and whether it could be that AI and robotics are not the only trends that are really going to focus and refocus the future of surgery.
Yeah, great question. I mean, the future of surgery is a fascinating topic. We're living in extraordinary times, as we've been hearing. And the Royal College of Surgeons of England got the great and the good into a room back in 2017, 2018 to look at and predict what they thought the next 20 years would look like in surgery. They produced a glossy report, and AI and robotics, as you allude to, were in there, but they really predicted more of a transformative shift from what we currently do now, which is reactive, symptom-driven surgery, to a far earlier, more personalized, more precise, less invasive type of surgical care. And that's underpinned by the digital, the biological, and the technological changes and opportunities that we've been hearing about. So in addition to the robot and AI, you've got augmented reality, or the omics revolution, which is probably even more important than robotics in my mind, stem cell therapy, nanotechnology. I mean, robotics is talked about a lot, and it is what all the governments keep talking about. And our health minister in the UK stood up in the autumn and said we're going to do all surgery robotically in the next 10 years, which I think it has its benefits, but I think it's not a panacea for everything. We might come back to that later, perhaps. But yes, that report is interesting to consider. And your question was around prevention. That Benjamin Franklin quote, "An ounce of prevention is worth a pound of cure." We all know that. It applies to many things. I often talk about it when I'm giving talks on incisional and peristomal hernia. As an abdominal surgeon, preventing the hernia from existing is so much easier and cheaper and better than trying to deal with it when it arises. But in terms of operations that we do that are potentially preventable with preventative medicine, there's loads. If you think about pretty much all of vascular surgery, the majority of cardiac surgery, a lot of cancer surgery, a lot of orthopedic surgery, gallstones. The bariatric surgical specialty came into existence 20, 30 years ago as everyone got more obese. And that's an interesting place to start, because GLP-1 medication, as we've all seen the explosion in the last 2 or 3 years across the world of that, is a fascinating case study. We've seen that people are buying it mostly privately, certainly in the UK and I think in America. And they're completely changing the face of what we're operating on. They've got rid of bariatric surgery. It almost doesn't exist as a specialty, which is great in some ways. It's widening healthcare gaps, and the rich are accessing a drug that the poor probably need. And it's not really preventative medicine, but there might be some, because you're supposed to be obese to qualify for the drug. And we know that's not always the case, interestingly. But there might be some interesting parallels there that we can learn from as to how that's been marketed and rolled out and taken up by the world. The other things, we all know them, more exercise, better diet, don't smoke. There are known and well-documented issues with preventative medicine, whether that is education at an individual or a societal level, whether it's the access, both financial and logistical, to healthy choices. We know they're traditionally more expensive. But I think it comes back to human nature as well. It's all well and good talking about shifting things, but humans are humans. We increasingly live, as we were discussing earlier, in a kind of immediate gratification type world, and it's far harder to make choices now that won't impact you in a good or a bad way for 20 or 30 years. But we've somehow got to get there. As you said, it's a burning platform. We can't continue as we are now for much longer.
Absolutely. And Bernard, I spoke about Mölnlycke's internal aha moments, where we've understood a customer need and we've translated that into an innovative solution that has become very successful in the marketplace. But it reflects the balance between technical and adaptive change, and how hard it is for those to be done simultaneously, but absolutely how essential it is. And so, Bernard, how can we truly embrace radical innovation that leads to adaptive change in a company that is so deeply rooted in its legacy?
I'll start by saying that the legacy that you have here is a gift. Right? You have built the company to where it is today. We should not take that for granted. However, the legacy that we have can also be a burden. Right? So I would say, honor the legacy, honor the technical excellence that this organization has. But we need to think of breaking beyond that so that we can continue to grow. And I'll just focus on 3 points. Number one is be brave enough to audit our successes. How did those successes come in the past? The challenges today are echoes of yesterday's mindsets. So instead of 2045, let's say 2030, as Lato has said, that will people look at us and say that, well, you are waiting for wounds to get severe when you can start preventing and predicting them now? So that's point number one, right? Challenge our mindset. Point number two, technical versus adaptive. I mean, technical is quite easy, right? It's incremental. Make your dressing 10% more absorbent, make your dressing smaller, better. But that's incremental. That's not going to change the game. When we move towards an adaptive thinking, it's like, should we even make dressings? I don't know. That's a question that for all of you leaders to do. Shift from volume producing to value. What value do you bring besides just producing the product? Right? Move towards health outcome. The third point, which I think is very important, as Joe, you have said, is like the metro day-to-day excellence. That fuels the organization, keeps the lights on, and it will and must be preserved. But you need to look at the other train, the long train, the future, the one where you need to make time for, the one where most of us will not be comfortable as leaders. So as a leader, how do you make time for that, right? I'll close with this quote by our Minister of Health, Mr. Ong Ye Kung, right? It is not enough to be a steward. all of you as leaders are steward of the organization. We also need the courage to be enterprising. A failure to be enterprising to chart a new future for the organization is just as damaging as a failure to steward. So while we protect what is working today, be brave, be bold to build what's next.
Very true. So I think I broke you in gently. So now I'm going to ask a tough question. Innovation is never free. It requires investment, taking risk, and is often disruptive. So how do we reconcile the relentless push for breakthrough solutions with the harsh realities of affordability and the willingness to pay from the healthcare systems? And are we prepared to challenge entrenched cost structures and redefine what value truly means? And I'd like to hear each of your thoughts. Maybe Joe, you'd like to go first.
Yeah, if you think innovation is expensive, try irrelevance. Because if you become irrelevant, it happens very quickly. Everything's gradual until it's sudden in this new digital world. So I would probably start there. You referred to a burning platform before.
Yeah.
Matches are an amazing tool. Left in a 2-year-old's hands, they'll burn down the house. Put it into an educated person's hands, they can do amazing things. This world wouldn't exist without fire, appropriately directed. So I would say that first. Tom talked about AI and robotics. You know what that's a proxy for? That's a proxy for algorithms. They used to sit in the head of the surgeon. We could now democratize those and pull those up to a big thought system and share them and give advice to the average or below average surgeon. So it's a proxy. We got advisement coming out of data now, not just the advisement of what I've experienced. Now I can put that advisement into the hands of the operator. And then the democratization of skills. In the wound care business, it is a very expensive, episodic situation. Mm-hmm. And so the person who can solve that early and solve it beyond the episodic and move it way upstream on that digital, that's where that investment should be. And the liability is that we've always done it this way.
Yeah.
And tomorrow, we might not have a way anymore. So I would say those are the points I think about when we talk about the expense of doing something, the expense of not doing something. When Mölnlycke's sitting there with a box of matches in an educated hand, you're not a 2-year-old child. You're a 2-year-old child in digital transition. Mm-hmm. Your leadership team needs to give the room, space, investment, and liberty to drive this in the hands of an expert. And then that phase change I continue to refer back to and bring it back into the organization.
And Bernard?
Oh, as Joe said, innovation is never free, right? Demands investment, demands risk, demands us to challenge ourselves. Right? And affordability cannot be an afterthought. Right? We need to redefine value, not just at a costings. We need to redefine value by the outcome for each dollar spent. Right? I mean, if the solution prevents complication, shortens recovery, preserves dignity, that's real value for the patient. We used to measure lifespan, someone lives up to 90 years old, 80 years old. That has to change. In Singapore, we look at lifespan and health span. Health span is how long you stay healthy. Lifespan is how long you live. You could live up to 80 years old, but you're only healthy up to 70 years old. That's a 10 years gap that you're living an unhealthy life, being a burden to the society, to the family. That gap in Singapore is 11 years between health span and lifespan. And we are, and we should, and all of us should try to aim to narrow that gap for our world. Right? Because I think that's what we want to do as a society and as an organization, and that's what we want to do when we age, right? So I would say it's not that we can't afford innovation, as you rightly said. It's can we afford not to? And I'll end by saying that innovation and affordability aren't opposites. They are partners working together to create a sustainable health.
Interesting. Tom?
I agree with both, of course. But But in the real world, it's difficult, isn't it? That innovation paradox, that we want things to be accessible and affordable when they do exist, despite taking years of risk and money and time to create, really involves us somehow reconciling how value is rewarded. As you say, and most healthcare systems across the world are set up to reward and to pay for short-term outcomes. They're set up around budget predictability, established funding models, and therefore anything that we innovate that produces long-term benefit or preventative benefit, something that may never even happen, that would have otherwise happened, is really hard to pay for. So that's just outside of what we currently do, and it's outside of who is currently paying's horizon. In most countries, it'll be a different government in charge of the country when that reward is realized. So that has to be squared. The only way we can do that is to keep the patient at the center. And as you say, maybe they're not even patients. Maybe they're public because they never become a patient.
Yeah. So I'm sure we could sit here all day, but we have a few minutes left. Final thoughts, Joe?
Well, Tom touched on it. Healthcare at large, as we look at it around the world today, regardless of the region of the country, it's become a series of self-optimized silos. They've become incredibly efficient of optimizing only what they work in. They don't look over into the next person's foxhole. And that probably is going to change. And it's going to be driven by what drives every decision in this world. Not the right thing to do, but economics. So you have to follow the money. So we have that self-optimization that we've got to help break through. Mölnlycke can be a leader there. How can they be a leader? Their focus can stop being at the episodic site of care and become a wound care management aggregator of the entire system. That's what their goal should be. The same way Bernard said, should we even be in wound care? Well, the first thing you have to do is define wound care. Wound care as we define it today is highly predictable, the box the last 175 years have put us into. We need to move up that chain and own the system that originally looks at the wound, because that's usually where our business is, and then directs all of the activity down. And if our wound care dressing is at the bottom of that, fantastic. At least we own the whole system. And our revenue changes from opening up a packet of a product to directing where the entire wound care system should go. And our future products in Mölnlycke have very little to do with the current products.
So you think we should be the Amazon of the healthcare world?
The Amazon or the Apple. Both of those are great examples of a digital transition of owning the ecosystem, and everybody else below that is subordinate to it, and you don't want to be caught on the subordinate end of that system.
Yeah. Tom?
I'm a surgeon, and I think I've got a few more years left in me. So I think
The question is, are you a distinguished surgeon who doesn't need a robot, or are you a lower level surgeon who needs a robot?
Which would make him in the minority. Most of them need
I
one.
think everyone's got it wrong with robotics. I think people think it's going to make surgeries, better, safer, more automated. Great surgeons barely need robots. There are a few indications, and there are a few times when it makes it a few percent safer. And I would have a robotic operation if I needed a deep pelvic surgery, for example. We were discussing earlier that auto lane correction that your car does and it's very annoying as you're trying to drive. That same technology is now in robots, and it will stop you cutting the ureter or the blood vessel that's aberrant, that shouldn't be there, overlaying the scan onto the patient in real time. That's incredible. But what robotics will actually do for the global health is make bad surgeons better, not great surgeons slightly better, and you get such incredible information about the objective nature of the surgery itself, the wasted movements, the wrong movements. It may even help us get better surgeons, because it may get rid of some people who aren't even that good, because we have the skills to do that. So I think robotics is here to stay, but it's in a slightly different way to how some health ministers think.
And Bernard, as the real innovator sat around the table, we'll give you the closing words.
You need to be comfortable being uncomfortable. As Joe said, when you come to work on Monday, what have you done? Can you try to make your Friday disappear, right? So the next time when someone comes to you with a crazy idea that you're not comfortable with, flow with it. Don't kill it. Give it a go. Get used to that. The second point I want to say is that you don't need to come up with a solution as a leader yourself. You may have the technological advantage here, but there are people out there that we can learn from, different industry, whether it's banking, whether it's finance, whether it's e-commerce. Learn from them. A successful company, a successful team will be someone who is humble, who is willing to aggregate all these things and make it work for them.
So I'd like to sincerely thank our speakers for their perspectives. I hope that you have found this not just informative, but also been inspired by these conversations. And really, these that will remind us that the future isn't something that we simply wait for. It's something that we actually create. And if today has made one thing clear, it's that the time for courageous action is now.